Hello again, everyone. Thank you for being back here with us. I hope that you had a good opportunity to do a quick reset and just get what you needed to continue with us for the next 90 minutes or so. Our next session highlights innovative workplace programs and tools to support mental health. Our speakers are going to present a brand new tool that can be used in workplaces, as well as a mindfulness program. Our presenters are Dr. Monique Gignac and Carter Hammett, and we will have some Q&A at the end of the session, hoping that we have time to do that. Dr. Monique Gignac is joining us again today after presenting a very exciting and engaging session yesterday. Dr. Gignac is a scientific director and senior scientist at the Institute for Work and Health, as well as a professor at the University of Toronto. Her research examines psychological factors like stress, coping, and adaptation, and their importance in understanding the impact of chronic health conditions on the lives of working adults. Of particular interest is research on workplace support, accommodation, and communication among individuals living with chronic disabling conditions. Our second speaker will be Carter Hammett, who is the Employment Services Manager with Epilepsy Toronto. He holds a Bachelor of Community Studies along with diplomas in journalism, social work, and adult education. His work has appeared in the National Post, the Toronto Star, and the Toronto Sun, and he is the author of 3 books, including Benchmarking, a guide to hiring and managing persons with learning disabilities. Carter's presentation will unpack the higher levels of depression and anxiety that are known to be experienced by people living with epilepsy. And he will also introduce Uplift, a mindfulness and CBT skills training program, and the positive outcomes it has generated for the community. I will now pass it over to Dr. Monique Gignac. Thank you for being here.
Thank you very much, Melissa, and I'll just try to get my slides here ready to go. Just want to be in slideshow. Okay, I hope you can all see that. Thank you very much for giving me an opportunity to come back again and speak, and I apologize to the interpreters. I will try to slow down today. I was given warnings. I think I'm hardwired as a fast talker, so apologies. I want to talk about the job demands and accommodations planning tool. This is part of a large partnership grant called ACE, Accommodating and Communicating About Episodic Disabilities. So I want to just run through very quickly the fact that we have a very large research team with different skills and a lot of individuals at the Institute for Work and Health who participated in this. We also have some tremendous partners who have been part of the development of the tools, and all the research that we've been engaged in. Realize is one of those partners. Thanks to Tammy and Melissa for always being there and participating now for several years in this work. We have an expert advisory committee of people with lived experience who have been helping us along with our communications tool. And I want to acknowledge the funding that we've received. Primarily, we've been funded by 2 of Canada's federal granting agencies, the Social Sciences and Humanities Research Council of Canada and the Canadian Institutes of Health Research. But we've also received some additional important funding from Canada Life in the early stages of developing some of the JDAP, and from Mars, as well as Employment and Social Development Canada. So yesterday, I tried to set up why we need to take a little bit of a different approach in the workplace in terms of how we address workplace needs for people with mental health, workplace support needs, and address questions like how do we help workers get support while respecting their privacy and the desire sometimes to not share health information with others? How do we help workplaces implement a transparent, a consistent and a comprehensive approach to assessing worker needs while still making them individualized, and where can workers and workplaces get support and accommodation ideas. So this has really been the focus of this ACE partnership. If I had to depict this, I might very simply show that we have, we have individuals who are working, they have a problem or a support need, and they wonder, should they say something? And they wonder, what can they do? So we know from some of our research that 43 to 60% of workers with a mental health condition have not disclosed any information to their supervisor, and it's their preference that they don't disclose information. We also know that workers aren't sure what supports are available to them, how to go about requesting them or learning more about them. And so this has really been the focus of ACE. We're developing two tools. One is a communication decision support tool, and the other is this job demands and accommodation planning tool, this JDAPT. And I'm going to talk about it today. Basically, what it does is it focuses on work demands that may be challenging at times or regularly. So it's taking the focus away from a health or a disability diagnosis and helping an individual work through the different demands of their job. So a person who is using the tool, and the tool is online, I'll give you the link, it's free to use. It guides a person through a series of simple questions about their job tasks and their working conditions. And then it provides a personalized list of support ideas that are relevant to those areas that a person has identified that may be challenging, to help people brainstorm and to kind of give people solutions. A person can keep this to themselves. It can be private. There's a number of ideas, a lot of ideas that someone can do on their own without having to share information. There are also then ideas that you might have to share, but maybe a more informal supports, and then the more formal accommodations where you might have to share some information, but you don't have to share the tool information if you don't want to. We submitted a prototype to an inclusive design challenge that was focused on support at work for people living with disabilities. This was sponsored by Mars and CIBC, and we were really happy when the JDAPT was actually the grand prize winner in 2022. We know we have more work to do, but it was real validation for the need for something like this, the gap that's out there. And so we want to go forward and do more testing, learn more, and improve the tool over time. But let me tell you a little bit about it. There are 24 different types of job demands or working conditions, and they're divided up into 4 domains. So there are some questions about the physical demands at work that a person might face. There are questions about cognitive demands at work, like having to concentrate for long periods, some questions about working with others, and working conditions, like having to work around distractions. There are 2 versions of the JDAPT. There's a worker version. That's the version that's available right now. So a person who's living with a condition fills it out. It's a self-assessment of their job demands and challenges. And there will also be an organizational version. This will be up in a couple of months. We're just programming it now. It's very similar to the worker version, but this one can be filled out by workplaces, either thinking about a particular worker or in general to think about the job and how could we maybe make this job more inclusive and supportive in general. So for workplaces, because many of them are trying to think about doing this, we have a bit of a job marker where workers, we have labor shortages. So workplaces are now thinking more about these kinds of issues. For each of the 24 job demands, a person is asked, is this important to your job? If they say no, they go to the next question. If they say yes, they're asked whether this particular demand is difficult for them because of their health, and whether that changes over time or is fairly constant. Because we know for a lot of mental health conditions, people will tell us they have periods of good health or good days, and other times when they aren't as they're experiencing challenges and difficulties with their work. When a person goes through all of these demands, they then get a personalized report, and this is linked to different support strategies and accommodations that they can think about. We know jobs are different. We know people's health is different. So we're hoping that there may be strategies that are helpful, but also people can use this to brainstorm and to think of ideas that are specific to them. So this isn't the way it looks. This is a busy slide. I'm not going to go through it all, but this is, for example, concentrating for long periods of time. There are things a person can try on their own. There are adjustments people can try at work that they may not need to request permission, and there are formal accommodations. So people get a list of this. If they hover over any one of them, the list opens up and it gives more concrete information about that particular strategy, what exactly we mean by this, to give people some more ideas. Over time, a person may see a strategy like, taking more breaks or things like doing refreshing activities, for example, up at the top here. So we also give people an opportunity to check things off so you can create a personalized list of support strategies for yourself. So you can either print out everything, you can save all of this in a PDF, or you can create a personalized list of those things that are more likely to work for you, or you want to try, or you might find work in your workplace. This is just a different slide showing if you had said that working with others was challenging for you, there are different strategies you can again try on your own or on your at your workplace, or formal accommodations. Again, each one will break out into more information. So we've been doing some assessment also to see whether or not this works. We initially, of course, started with a needs assessment to see what else was out there and identify this as a gap. We've done what's called a formative evaluation, which you do in the early stages, some outcome effectiveness, and in time we'll be doing some implementation evaluation to look at adoption of the tool. We've used a lot of different methods, in-depth interviews, focus groups. We've done environmental scans, literature reviews, and surveys. So I just want to give you a little bit of a flavor of some of what we've been hearing about the JADAPT. The first testing we did is part of this formative evaluation. It's something that sometimes gets called sensibility testing. What that means is you do this early on in the development phase of a tool or an intervention. You look at its comprehensiveness, its understandability, its relevance, feasibility, length, and overall impressions. This is usually very labor intensive. So for this study, a person filled out each of the 24 JADAPT questions, and then they were asked by the interviewers whether they understood the questions, whether they made sense, whether they could figure, this was feasible for them to fill out. We were looking for 70% of people in the study to endorse each of the questions. So that was the minimal level of acceptability. And if we got less than that, we knew we had to make changes. We had 46 workers with different physical and mental health conditions. We had 23 organizational representatives, supervisors, HR, and so on. And these people all came from really diverse organizations and job types. Overall, the sensibility assessments far exceeded 70% for most questions. Often in the 80s, 90s, we even had 100% agreement on some of the questions. We did add 3 new items and more examples. For example, one of the new items was working in areas where there's no opportunity to meet personal needs. So if you were at a kiosk in a mall, you don't necessarily have a quiet room or a space that you can go to be on your own. This is just an example of one of the things that we heard from one of the participants in this study. Someone said, I go in and just say, I'm dealing with a mental illness. And my boss says, what do you need? And I say, I don't know. I think the JADAPT might be better to help me understand actually these 3 aspects of the job are what actually are difficult for me. So let's think about what we do with those. And that was a common sentiment, that when you share a health condition, people may be sympathetic, they may want to help, but they don't know what to do. And you may not know what to do either. So this is where we hope that the JDAPT can come in and provide a lot of ideas. This study, by the way, is available on open access, and that's the link for it there if you're interested in reading more. We've now moved to the next phase of the evaluation. And so we're now looking at outcomes. We're going to have 3 waves of data here. At time 1, we asked people about their health, about their job and their perceptions about themselves. We then got them to fill out the JDAPT and asked about their perceptions about it. 3 months later, we went back to people and we asked, have you used the JDAPT and what are your perceptions? And we reassessed some of the job information and health information. And 9 months after the time 1, we're going to do the same thing, ask about use, how things are going, the job, and so on. We finished time 1. We had 279 participants. At time 2, we had 211 participants. That's over 75% of people back in the study, which is really terrific. We haven't lost a lot of people over time. We've also looked at whether or not people have made changes to their work. So at time 2, we found that over 72% of people had made some change to manage their work and health outside of work, which is terrific. We found that nearly 59%, nearly 60% then of people had made changes to manage work and health at their actual workplace, which is also great. When we looked over the comments to understand why people hadn't made changes, there were 2 big reasons. The first was, I didn't need to make any change. Things were going well at this point in time, but I will keep this in case I need it in the future, or I already have some of these accommodations that I need. The second big reason was this reluctance to share information with someone in the workplace. And so that's where our other work on communication, we hope will help out as well. And then we did find that about 1 in 5 people, 21% of people had actually shared the JDAPT with someone at their workplace, which is also very helpful. And I'll come back to that in a moment. But I just want to tell you a little bit about some of the changes that we've been seeing. So there's something called self-efficacy, which is very important to change. And this is a confidence a person has in making changes, that they can do it. So we asked, before anyone had seen the JDAPT, how confident are you that you can address the problems that you're facing at work related to your work and health? How confident are you that you're meeting your job demands or doing what you need to do? And how confident are you that you're coping, that you're dealing with the stress in the way you need to and the uncertainty? 3 months after completing the JDAPT, we repeated all of these questions, and the arrow pointing up is to let you know that there was a significant improvement. So people reported being more confident that they could problem solve, meet their job demands, and meet their emotional needs. And that was statistically significant difference between time 1 and time 2. We also asked people if they were having difficulty getting as much work done as others expected of them, and whether they were having work productivity problems. This was before they completed the JDAPT. 3 months later, people told us that this had decreased, that they were having fewer difficulties getting work done, fewer productivity problems. This is also statistically significant. But having something statistically significant doesn't mean it's necessarily a meaningful change, that it's big enough that you would necessarily notice it. So we calculated something called an effect size. And the numbers here, if you have a score of 0.2 or less, it means that, okay, you're maybe seeing a difference statistically, but it's not meaningful. We're not going to be able to see this in the real world. You get to about 0.5. Now, this is a moderate change that is something that people are likely to say is a meaningful change. We can see this in someone's life, and 0.8 or higher is a large change, quite a dramatic change. So you can see for most of the measures, the changes appear to be meaningful changes. They're moderate and even a large change in feeling that a person is confident that they can problem solve. The change is a bit lower for the work productivity. Lots of things affect productivity. We'll be looking at that going forward. It's certainly above 0.2, but it's not quite it's not a large change at this point in time. So just to finish off a little bit here, some comments about this study. And I've chosen these deliberately. One individual said, it was empowering to see how much one can do on one's own, especially when I'm hesitant about being supported by HR. And that was important to us, that people could find strategies without having to disclose information if they didn't want to. And then someone else said, I used the list of strategies and accommodation plans plus the language of the job demand summary to help me request a workplace accommodations plan. These tools were critical in helping me explain how my disability impacts my work and allowed me to think about possible solutions. The plan is still being finalized. Without the JDAP, I wouldn't have had the confidence to go through with this intimidating process and advocate for myself in such an effective way. So we're doing a lot of research. This is, I would say, the end of the beginning. We will be looking at the 9-month follow-up. We'll now have a chance then to look at things like absenteeism and short-term disability, productivity again. Want to look more at the similarities and differences. We asked all these questions about people's lives because we wanted to know, for whom is this working well, and where do we need to work harder to improve the tool. And we'll continue to enhance the support and accommodation list over time, and any ideas you have would be very welcome. So this is the link to the English and French JDAP for workers. It's, again, free to use. I want to emphasize, we don't save any data. We want to protect privacy. We know people are reluctant to have people know about their personal health. So we don't ask for information about who you are, where you work. We don't save any of that. You can save the information yourself in a PDF, but once you leave, it's gone. And the JDAP for organizational representatives will be uploaded, as I said, early summer. So thank you very much. And I will stop there and turn it back to you, Melissa.
Thank you very much, Monique. That really rounded out the presentation from yesterday. And it sounds like there are a number of people who are very interested in both the worker version and the organizational version. I have a couple of questions here for you, but I'm going to save them to the end, and I'm going to invite Carter to come and speak, and then we will get right back to you, Monique, okay? Carter, thank you so much for being here. I hope you're ready to go. You should be able to share your slide deck at this point, and I will just pass it along for you to begin when you're ready.
Thank you. All right, I'm just going to get my presentation up here, and I guess it would help if I did a screen share. Bear with me. Okay, everybody can see that?
Looks good, thank you.
Okay, great, thank you. All right, so my name, first of all, I just want to thank you for inviting me here to be part of this amazing day. I have been so incredibly moved by people's personal stories, their resilience, and the messaging that has gone out to participants today. It's incredibly moving and incredibly inspiring, and I feel honored to be a part of it. So thank you. My presentation today is, we're calling it Epilepsy and Mental Health in the Workplace, a community-based perspective. And what we're going to be talking about here is we're going to be spending a little bit of time on what exactly is epilepsy, epilepsy and comorbidities, and we're going to focus on two areas, depression and anxiety. And let me know if I'm going too fast, please, as well. And then I'm going to introduce a tool that Epilepsy Toronto has introduced about 2 years ago, and we'll talk about some of the outcomes attached to that. So I guess we can start with a definition of what epilepsy is and move on from there. So epilepsy is a common neurological condition. And when I say common, it affects about 1 in 100 people. And it's characterized by recurrent seizures. So epilepsy results from sudden bursts of activity in the brain. And whoops, sorry about that. This is a brand new computer too, so I'm still getting used to it. Hyperactivity in the brain, which causes seizures that vary in form, length, and frequency, depending on where in the brain abnormal activity is found. Epilepsy is also an individual and an episodic condition. Seizures can be provoked or unprovoked. Provoked seizures may result in things like trauma or low blood sugar or alcohol and drug use, whereas unprovoked seizures occur in the absence of precipitory factors. So by definition, epilepsy is a condition of recurrent or unprovoked seizures. Seizures are the symptom. Epilepsy is the actual diagnosis. Okay, so our brain cells communicate with our body by means of tiny bursts of electrical activity. The seizure is a brief disruption in normal brain activity that interferes with various aspects of brain function. And on occasion, sometimes a large group of brain cells can have what I'm going to refer to as an erratic discharge, electrical discharge, causing a seizure. And our body's reaction, its response to that discharge, is by having a seizure that may take many, many different forms. Some seizures might only affect 1 or 2 functions. Other seizures affect a wide range of brain functions. And I think the other thing that might be helpful for you is that a typical seizure may last a few seconds or a few minutes in length, and it can manifest in many different forms. Some people are a lot of people in my experience have tended to think of epilepsy as being convulsions. There are actually over 40 different kinds of seizures. And sometimes they aren't always easy to identify, especially when the person is having one. So now we know a little bit about epilepsy. We have the foundation. And let's take that and put it into the context of the workplace. So some of the central issues affecting workers with epilepsy are a lack of knowledge about the disorder and epilepsy's perceived impact in the workplace. The ignorance resulting and misunderstanding can produce unnecessary fear and anxiety in both employees and employers. And I want to emphasize that this is really a two-way street. So some of the employees' concerns include things like stigma. There is an awful lot of stigma attached to invisible and episodic conditions. Further concerns include things like negative and uninformed attitudes. Occasionally, you still come across employers who outwardly discriminate. There are examples of unnecessary driving requirements that didn't exist before in somebody's job description. There is a fear of potential repercussion after disclosure and underutilization of their skills. I'd like to point out a couple of things. First of all, I have a client who deals with medication side effects that includes jittery hands, and he happens to be a lab technician. So one of the things that, one of the issues that he brings to the table is that his employers will not let him conduct experiments for fear of dropping glass, breaking tools, etc. So he has a degree in science, and he is regulated to cleaning the lab, basically, and cleaning test tubes and things like this, when he's obviously far more capable. There's been no discussion, no conversation about any kind of accommodation that might actually enable him to do his job. So we're currently working on that. So that's one example of where employees can be underutilizing their skills. On the other hand, as I said before, excuse me, this is a two-way street. So employers will often bring concerns about productivity, absenteeism, liability is a big one, job performance, concerns about the reaction of their clients or their coworkers. Many people report walking on eggshells when they understand that somebody is has epilepsy, and there's a lot of anxiety which takes place, which falls squarely into the what if category. There's also, I'm surprised to say, but there's still an awful lot of concerns around accommodation costs. And finally, workplace safety is key amongst many, many different employers as well. So I really appreciated Monique's presentation about accommodations, and it sounds like it would be an incredible tool for a lot of our folks as well. So I want to just also emphasize that there's very little difference in job performance or productivity amongst workers with epilepsy or workers without epilepsy. Studies have shown that work performance, cooperative behavior, productivity, and stability of workers with a seizure disorder is equal to or greater than that of their counterparts who are living without this condition. It's interesting that absenteeism is lower as well. And part of the reason is because people living with epilepsy often practice good self-care. Another thing that might be surprising to some folks is that accident rates for workers with epilepsy are significantly lower as well than their non-epileptic counterparts. Some studies have even shown that people with epilepsy actually work more attentively and productively than others because they're trying to prove themselves in the workplace. They understand what discrimination is. Having said that, I think it's really important to understand that while most occupations are accessible to workers with epilepsy, there are some conditions where we try to gently dissuade or discourage, depending on the type of seizure that's being experienced, the reaction to medication, the frequency and intensity of the seizures as well. So this is a small list, but it does include things like airline pilot, joining the armed forces, the police, or other occupations where firing arms are going to be used, firefighter, bus driver, or lifeguard. Those are some of the jobs that we try to dissuade. All right, so comorbidities in epilepsy. I don't think I've heard that word today. But it's estimated that about 85% of all people living with this condition also live with some form of disability or disease that intersects with the epilepsy itself. There's going to be many times that we are supporting folks who are living with seizure disorders, but those conditions, as a matter of fact, I think it's important to mention that about 70% of people living with epilepsy live with it well. They're able to work, they're able to travel, they're able to marry, have families, and live productive, holistic, healthy lives. So we work with the 30% who unfortunately, for whatever reason, do not live well with it. Sometimes the seizures are intractable. And on top of that, there may be coexisting conditions. In fact, this is the norm, not the exception. that may actually be worse than the seizures themselves. So some of these conditions include things like cerebral palsy, sleep apnea. I would say over about 75% of our folks have memory issues, migraines, diabetes, and the following. So about 50% are living with coexisting mild intellectual disability or some form of autism spectrum disorder. About 25 to 30% live with a learning disability. There's over 140 different types of identified learning disabilities, and probably a whole lot more that have yet to be identified. But some of the more common ones are things like dyscalculia, which has been recently reappraised in recent years, dyscalculia, which is sort of the numerical equivalent of dyslexia. Largely present is ADHD, or attention deficit hyperactivity disorder. And by the way, these two disabilities right here are very often missed in terms of the diagnosis. It manifests very differently in boys than it does in females, and that's a whole other workshop. But what we're going to be looking at today are a couple of symptoms associated with mental health. And specifically, we're going to focus on anxiety and depression. So depression is the most commonly identified the most commonly identified comorbidity in people living with epilepsy. So about 35% of all folks living with seizure disorders have coexisting depression. In fact, they're about 3 times more likely to have active depression than those without epilepsy. So people with both epilepsy and depression report a higher perceived severity of seizures. Research has definitely shown that depression and other mental health conditions can actually increase the risk of epilepsy or make it worse, and vice versa, unfortunately. This impact complicates treatment and often contributes to worse outcomes. So for many, many people living with epilepsy, stress explains depression, but acute and temporary seizure-related states of depression have also been reported. AEDs are anti-epileptic drugs, and these have also been known to affect mood and potentially increase seizures. Okay, so some people with epilepsy, brand new computer, thank you. So some people also experience depression immediately following a seizure. So the seizure ends and the person is going through a period of coming back into consciousness, but they may experience depression after a seizure, and this is called post-ictal depression. The most commonly diagnosed seizures actually occur in the temporal lobe. These are called focal aware seizures. And folks who are living with this particular type of epilepsy are more likely to experience depression because the seizures actually start in that part of the brain that is primarily responsible for regulating mood. So depression, even more than seizure frequency, affects reduced quality of life. And that's partly a function of stigma. Epilepsy and depression are both stigmatizing conditions. That stigma often compounds social isolation. So we are left to understand that people are left to manage on their own. Many times they're living in isolated circumstances in rural areas with limited access to transportation because they can't drive or they don't have access to the bus. And some people also living in situations like that can't easily access counseling to treat their depression either. Okay, so another big presence in epilepsy is anxiety, and about 25% of all people living with epilepsy also have coexisting anxiety and or depression. Stress, as we know, can be a major trigger for seizures. The anxiety can also occur as a reaction to diagnosis, as a symptom of some seizures, and occasionally as a side effect of anti-epileptic drugs. Sometimes people experience what are known as auras, which is actually a type of seizure, a sensorial seizure that people use as a warning before a larger seizure may happen to occur. They can exist on their own, they can exist in tandem with other seizures. And sometimes the form that these auras take is anxiety. So, once again, more people are often feeling isolated or rejected due to epilepsy, and these folks may experience anxiety symptoms as well. As I mentioned earlier, anxiety can actually be part of the seizure itself. So this can occur at the beginning, or it may happen immediately after. For some people, a large part of the temporal lobe epilepsy or the focal seizures feel a sudden fear at the start of a seizure, and this is a good warning signal. Again, though, that form of fear could take many, many different forms. Other reasons why anxiety may be present are the psychosocial impact of living with an episodic condition, including the stress of an epilepsy diagnosis or the ongoing fear of potentially having a seizure. It's at this point that I tend to ask my clients, do you own your epilepsy, or does your epilepsy own you? I've come across many, many people who don't understand what, or don't have the vocabulary to be able to describe what is happening to them. And I find that that is a good chunk of the battle when they're actually able to identify the language that goes along with living with a condition like this. It provides a kind of grounding that people can actually move forward with. So anxiety disorders tend to be more common in people with epilepsy compared to the rest of the population, and this can have an enormous impact on the quality of life for somebody with a neurological condition. Okay, so I just want to actually add, there are a couple of odd things here. There may be an associated neurological condition or possibly a psychiatric condition. Part of the problem here, I find, is that a lot of psychiatrists are not necessarily well versed in neurology, and a lot of neurologists are not necessarily well versed in mental health conditions. Genetics may play a role here, although this is studies that it's really very, very young. And there may also be underlying brain mechanisms that are related to the epilepsy, and that can potentially influence anxiety as well. So the question becomes, what do we do about it? Often, as I mentioned before, the seizures may be well controlled, but the anxiety and the depression isn't. So back in 2006, at Emory University in Atlanta, Georgia, somebody got the bright idea to combine mindfulness, which people knew very little about at the time, and combine it with a cognitive behavioral therapy. Out of that came a program called Uplift, which is an acronym for using practice and learning to increase favorable thoughts. So this aims to help people with epilepsy who are living with anxiety and or depression and stress to improve their mental health by facilitating skill development within the context of a group setting. It was originally designed actually to be conducted over the telephone. And with the pandemic, we were able to pivot and move the program over to Zoom, and it's had tremendous success. So the program is 8 hours in length. It consists of 8 one-hour facilitator-led group discussions. And one of the things that I find makes this program unique is that there is always a co-facilitator helping out with the program. And that co-facilitator has to be a person with lived experience. So together, we wind up leading participants through a curriculum of mindfulness exercises and cognitive behavioral therapy exercises. Some of the skills, so it's really important to emphasize that this is not a support group, although there is a supportive component to it. But it's really, the emphasis is more on skill development. And some of the skills that come out of that in terms of favorable outcomes are including things like recognizing and questioning distorted thoughts, or unhelpful thinking, as I prefer to call it, shifting attention when you're distressed, and reacting less to disturbing thoughts. So with Uplift, again, some of the target populations include people living with depression, stress, or anxiety associated with comorbid epilepsy. There are also programs for caregivers who are living with depression and stress related to the support of people with epilepsy. And over at Epilepsy Toronto, we use it to support job seekers, which I'll come to in a couple of seconds. I think it's one of the things that it's important is that the program embraces diversity and inclusiveness, and it addresses some of the intersections associated with barriers attached to epilepsy, and that includes cultural background as well. They've done tests, pilots in the States, and found out that the BIPOC population found it relatable. It was also culturally adapted for Hispanic Americans. And once the language was changed and put into a cultural context that could be processed and understood. Okay, so some of the goals, the primary goal behind Uplift is to be able to empower people to improve their own mental health through the acquisition of mindfulness and CBT skills. Part of the reasoning for this is that our thoughts and activities affect our mood, stress, and anxiety. By attending to our thoughts, we can learn which thoughts affect our mental health. And by learning to challenge those thoughts, we can let them go once we're empowered to believe that we can improve our mental health. And there's also a somewhat obvious but necessary component to remind people to engage in pleasant activities that can also improve mental health. Okay, so I just want to spend a minute or two on this. One of the things that surprising outcomes and pleasant outcomes of Uplift is that we introduced it 2 years ago, which almost coincided with the beginning of COVID. And so a lot of folks and a lot of communities, by the way, went into lockdown during the pandemic, and we were able to pivot into a Zoom-based context that really had no impact on the delivery of the program because it was actually conceived with distance in mind. So as I've mentioned before, a lot of people with epilepsy tend to feel fairly isolated living in these situations, but Uplift allows them to connect with other people who are going through similar experiences. That goes back to sharing some of the stories that we started today off with, in which we're so moving. A lot of the time, even though people's own family members aren't able to relate, they don't understand. And so Uplift is able to give them tools to help them manage the condition and improve their life satisfaction. I don't have detailed outcomes. I did not really want to focus necessarily on that, but what we can tell you is that during our pre and our post evaluations, most people reported a reduction in anxiety and depression symptoms and an increased ability to manage those symptoms by about 50% more or less. What was nice to see was that participants demonstrated a lot more knowledge about coping with depression and anxiety coming out of the program than they did walking into the program. And one of the really nice outcomes of the program is that it's also had a significant impact in actually reducing the number of seizures of people living with epilepsy. And what does that mean? Well, that actually means fewer emergency room visits. It means less ambulances that people living with the condition get very frustrated with when they don't really need to go to the hospital in the first place, and lower costs of care. So Epilepsy Toronto offers Uplift several times a year. We offer it to adults, caregivers, and people seeking employment, and it's offered in several chapters across Ontario. We use it to help both people looking for work and attempting to maintain work, and it's been proven itself to be extremely useful in interviews, disclosure of a disability, job maintenance. A lot of folks with epilepsy are great at finding work, but they do have trouble maintaining work. So it's also been useful for onboarding, for training, and as a wraparound service. This is one of several programs that we offer at Epilepsy Toronto. We are the only employment program in the country that offers employment support to job seekers living with epilepsy. No pressure there. So we divide our services into two parts. We offer intake and assessment, case management, career planning. I myself do a lot of counseling workshops. We have a job search support group that's become one of our flagship products. And we also, in addition to Uplift, have recently introduced a new program, also out of Emory College, called Hopscotch, and that is a memory enhancement program. Some of the people who have gone through Uplift actually report with the increased ability to manage stress and anxiety, going into the Hopscotch program has actually been easier for them because they have enhanced their own toolbox. We also help people with job placement, client supports, employer relationships, and the standard job search as well. And one last thing before I shut down for the my portion of this presentation. There's a wonderful website that called epilepsyatwork.com, and it was funded by Enabling Change Project out of the province of Ontario, and it's a very good, comprehensive introduction to epilepsy in the workplace and how to manage your symptoms. So I think what I will do is I will leave it there and just say thank you very much for taking the time to listen to this, and thanks for having me. It's really appreciated.
Thank you very much, Carter, and thank you for giving us a sense of epilepsy and the role it plays in people's lives at work, as well as the specific program. There are a couple of questions that have related to whether or not Uplift is available across Canada. And my impression is that this is a program that you can enact yourself at your organization. Is that right?
It is. It's not without costs or training. It is available, to my knowledge, I believe, in BC and Alberta, and I know that it's been recently introduced in a couple of places in Ontario. I think that might cover it for the time being. Again, some chapters are limited because of their size or their budgets and some other variables that may impact that. But again, it can be offered online. So we often refer people to other chapters closer to home that are offering it too.
Okay. Thank you very much. I have tried to keep on top of the questions. A couple of people were very interested in links to the JDAP, so I've tried to make sure that they have access to those. We are rolling right into our keynote speech at this point. So if both of you have a couple of minutes just to have a look at the chat to see if there's any questions that have come up for you that you might be able to answer. There's a lot of great complimentary things happening there and some interest in the newsletter so that people can get updates on when the organizational JDAP tool will be released. So hopefully most of those questions have been answered for folks because I do need to move on to the next session. But my thanks to both of you for being here today. This kind of information is always so helpful, and it's really tough for us to get a hold of, especially as we tend to work in sector specific silos and only within our own small communities. So thank you both for highlighting the work that you've been doing, and it was wonderful to hear from you.